Bismillahirrahmanirrahim. Mr. Chairman, my dear professors and colleagues, first of all, I'd like to thank Professor Helnan for giving me this very important topic to talk about. So I'm going to speak about pair donation, and pair donation is when two incompatible pairs, they exchange donors to receive compatible pairs. So they exchange or they swap, and this is a form of living donation, of course. So I'm going to speak about the indications, the types, the history, innovations, and the situation of KPD, kidney pair donation in Egypt, and then I'm going to conclude. Well, the reasons for participating in KPD programs is the presence of incompatibility, which could be due to ABO incompatibility, especially those with the O group. They have antibodies for the A and the B, and it's not very easy to find a compatible donor. The HLA incompatibility or sensitization of the recipient against the donor due to previous blood transfusions, pregnancies, or previous transplantations. And of course, the calculated pan-reactive antibody and the level correlates with the difficulty with which the recipient is going to find a donor, because we're going to have a big list of unacceptable HLA antigens and, of course, a longer waiting time. And if you look here, this is the waiting list based on the opt-in data as of January 2020, and you can see that the number of wait lists in the US for all organs is more than 124,000 patients, and out of those, almost 103,000 patients are potential kidney recipients. Another group of patients who come to the KPD are those who are compatible patients, but they wish to improve the quality of their transplants. For instance, if you have a relatively young patient with an older donor, like a mother wants to donate to her son, and they hope to find a younger match, or non-sensitized patients who have HLA mismatches with the recipients, but they need to improve the quality by having more. They have the goal of increasing the number of matches that they share with the donor. And that's because antigen match matters. If you compare here the half-life of the 6 antigen match, which is 41.4 years, as compared to lesser antigen matches, they all range between 22.6 to 26.5 years. And because the donor age matters, again, if you compare those who are 65 years and older, the 10-year survival is 29% as compared to younger age groups, which ranges between 56% and 62%. So this donor is incompatible with the recipient and is going to give to this recipient, and vice versa. And this we call a 2-pair exchange. You can also have a 3-pair exchange when this donor gives this recipient, and then the donor will give the other recipient, and the third donor will give this recipient. And you can have 4-pair exchange, 5-pair exchange, and at the end of the day, it is a closed chain. It will come to an end. On the other hand, if you have an altruistic donor or a non-directed donor, this is a donor who wants to donate to somebody he doesn't know, just to improve the quality of his life. So this donor is going to give this recipient, and then the donor of this recipient will give the other recipient, and it will go so on and so forth, and it could never end, may never end. So this is called the never-ending altruistic donor chain. It can only end when one of the donors will give the kidney to a patient on the wait list, and this is usually one of the hard-to-match recipients. So it's more like a domino. Each donor gives the fitting recipient, and so as such, one altruistic donor will help many patients to get transplanted. And this is one of the topics, how 6 extraordinary acts of kindness saved 100 lives. So it first started on a small scale. This matching of donor-recipient pairs was managed by the local hospitals and by partnering with the area hospitals. And it was the idea of Felix Rappaport, and then it first started in South Korea in 1981 and in Switzerland 1999. United States started in 2000, and in Netherlands 2003, and in Canada it started at 2005. And then the United Network of Organ Sharing, they started to do multicentric kidney paired programs throughout US. And then it spread through the rest of the world in many countries. And in the US, we have the federal government organized registries, but there are also other registries like the National Kidney Registry, which is one of the biggest registries worldwide. And you can see the numbers of the paired organ donations increasing over the years, starting from the year 2000 to 2012, and still increasing up till now. It is approaching or almost approached 1,000. And these red bars are the National Kidney Registry, and they are really contributing with a bigger number of kidney donations and paired kidney donations. And of course, the wider it gets, you will have more chances to have more optimized sharing, and you will have more chances to accommodate those who are hard to match recipients. And of course, it requires a sophisticated algorithms and software platform. And this is just an example. This is one of the programs, the Alliance of Paired Donations, with the first match for the ABO incompatibility, and then they go on for virtual cross-match after excluding the unacceptable HLA antigens, and they give points for the age difference and on the number of B locus HLA mismatches and the DR locus HLA mismatches, and they give points for the high serologic pan-reactive antibody of the recipient, and they give bonus points for those younger than 18 years, for those who were donors themselves, and for CMV negative to CMV negative, for Epstein-Barr virus negative to EBV virus negative, for zero antigen mismatches, and for those who are, and they give bonus for those who are on the recipient's wait time. This is one of the interesting papers, which is innovations in kidney paired donations that occurred over the past years. And according to this paper, one of the most important innovations is the shipping of living donor kidneys across the US. Before that, the donors had to travel to the city. This started in 2008, actually. So before that, the donors had to travel to the city of their matched, KPD-matched recipients, and they undergo surgery in unfamiliar circumstances away from family and friends. Now the kidneys are shipped on commercial airlines. They are not attended, they are not accompanied with a GPS, just to know the whereabouts of the kidney, and that's it. So by doing so, this encouraged donors to donate, and this really resulted in an increase in the donor pool. And there are many articles stating that the long ischemia, cold ischemia time is no big deal really. This is the oldest and the coldest. One of the articles, shipping living donors, it was in 2,363 patients from February 2008 to May 2018. Delayed graft function and descended graft failure occurred in 5.2% and 4.7% of cases, but there was no significant association between delayed graft function and donor age if below or above 65 years, and the cold ischemia time if more or less than 16 hours. Actually, the kidneys are put in an ice box, not even attached to a pump for the KPD programs. Now, another very important innovation is the voucher, and this really took KPD a step further by resolving the problem when the donor and the recipients are incompatible by time. For instance, this is what we call advanced donation. Here, the donor, for time constraints, can only donate at the present time, even if his paired recipient has not yet found a matched suitable donor and is not scheduled for surgery. This study was done by Fleckner and colleagues, and 10 such donors have facilitated 47 transplants. And by the time this was published, 2015, 8 of their paired recipients have received a kidney between 2 weeks and 19 months. Now, this is another thing, again, for the sake of the time, it's the banking. And that's again when the donor is not able to donate at the present time because his recipient is not yet in need for a kidney, but then he will not be able to donate in the future time because of aging, because of expected mortality, of other events like work, travel, or pregnancies. So what they do is that they donate the paired kidney to the paired kidney program, and in exchange there is a commitment made to have the recipients to have the priority to receive a living donor transplant whenever and if ever needed. So this is the voucher donor. It's going to act like an altruistic donor, and it will open a long chain, and it will help many patients to get transplanted. And when the recipients of that donor will need, if ever he needs a transplant, then he will be given the donor that concludes the chain. Another thing in the innovations is the laboratory innovations, such as cryopreservation, which increased the convenience for donors, whereas improving the speed of the paired exchange programs. And really the success of KPD, it does not only rest on the surgical procedures or the immunosuppressive medications, but it has to do with the mathematical and logistical optimizations. With advancing in the programs, there is more complex mathematical algorithms, computer software, and one of the examples of the logistical optimization is that the image of the kidneys from the donor hospital can be viewed by the recipient's surgeons anywhere, anytime with a click of the mouse. And why is everybody pushing for the KPD to evolve and increase? And that's, of course, you all know that living donor kidneys last longer than the diseased kidneys, and we all know also that preemptive transplantation has a greater 10-year survival as compared to transplantations after 24 years of dialysis. And these are the outcome of the National Kidney Registry as compared to living donations in the US. And you can see here that with increasing years, the outcomes becomes better, and this is probably due to superior avoidance of antibody. In spite of the fact that it has more difficult cases, like those with more cold ischemia time, hypersensitized patients, highly sensitized patients, and more retransplants. Now, what about KPD in Egypt? In Egypt, we are overpopulated, so we should have donors, but unfortunately there is lack of awareness to living donation, not to mention the altruistic donation. So this is something we have to work on. And of course, it's easier to transport organs. We don't have the vast area like in the US. We don't have to ship organs. We can just take it by car, and it's up to 16 hours. Cold ischemia time is no problem. We can start from others, and I know we don't have to invent the software. I know of international organizations that are willing to help us for free and give us their softwares. We can start simple, say you're doing a couple of paired donations on 2 or 3 couples. We can start on a small scale, including 2 or 3 centers. We can learn from the experience of others by making things easier, by not having to donate in the same time. I know that it was insisted before that donors should donate at the same time for fear of one donor refusing to donate after the first donor has done, but I think we have to have rigid rules for that. And one of the things that is going to help to encourage donors to donate is when they are reimbursed for surgical procedures and travel expenses, and maybe 1 month's salary, which calls for a national organization, and what's more important is a high level of coordination between the hospitals and the national organizations to have at the end allocation done according to the principles of equity, utility, and justice, besides the being medically sound, of course. What are the options for patients with unmatched donors? So either that the patient will discard transplantation, which means that he's going to live the rest of his life on dialysis, or he's going to look for a deceased donors, which means that he's going to have a long wait list. It's going to amount to years, 6 or 7 years. And besides, we don't have that in Egypt yet, in spite of the presence of the law. Well, the third option is to have to do desensitization. And yes, we know that there is survival benefit with kidney transplants for HLA incompatible living donors. And this is one of those studies, the very many studies which show over 8 years there is a significant survival benefit for those for recipients of incompatible transplants as compared to recipients on the wait list, or had a deceased transplant as compared to the wait list only recipients. But again, whatever protocol you're going to do, you will be using expensive medications. The standard of care, the thymo, the IVIG, the rituximab and plasma exchange, and you remember the many evolving drugs that Professor Henny mentioned yesterday, these are expensive things. So you will have a great cost, and you will subject the patient to immunosuppressive medications, and at the end of the day, antibody-mediated rejection is the risk occurring in 50% of those HLE incompatible grafts, with a 2 times increased risk of graft loss if clinically silent, and 6 times increased risk of graft loss if associated with graft dysfunction. And this is just to show you that the desensitization rate for the National Kidney Registry are dropping with increasing the numbers of the KPD. Now, the last option is to have another donor, which could be a KPD or a commercial donor, which unfortunately exists in Egypt. Of course, in the absence of a KPD program, we will have to handle the program. I don't know how it's going to be handled. So this is one of the very interesting articles that I came across, published in the Journal of the Egyptian Society of Nephrology, 2018. Kidney Pair Donation Program, a National Solution Against Commercial Transplantation, by Professor Hussein Shaisha, Professor Muhammad Abdel Gawad, Muhammad Tawfiq, Muhammad Rigel. And they came to very interesting suggestions to establish a national kidney pair donation program in Egypt, establishing a national organization for KPD program, defining transplant centers participating in the program, setting up rules for donor allocation and matching, standardization of laboratory and imaging testing for the donor on national basis, setting up donor follow-up clinics with full insurance in a consistent manner for donor safety and as support for their donation, and acquiring sufficient financial support for the program. In conclusion, Mr. Chairman, kidney pair donation is a remarkable innovation in and of itself. It has the following advantage and increases the number of kidneys available for transplantation, allowing the most incompatible pairs find a match and get transplanted, avoidance of the risks and costs of desensitization strategies designed to remove anti-donor antibodies, decreasing the waiting time on national transplant lists, and provision of living donor grafts, which are usually superior to cadaveric ones. And at the end, put an end to commercial transplantation. And by including ABO-HLA compatible pairs, this is going to increase the chance of finding a greater HLA match and a younger donors, which is correlated with more kidney life years and will increase the donor pool for difficult to match pairs. And I dare say that KPD is the best option for living donation and should be considered for all potential living donors, and it's badly needed in Egypt, especially with the absence of deceased transplantation, the non-familiarity with ABO incompatible transplantation, and the high cost of desensitization and the existing commercial transplantation. And thank you very much.